Care Everywhere, but the problem is that's one at a time. You need a population-based approach, and the only way to do that is to share population-based data, and so you need to go beyond just Care Everywhere to a system where the community pharmacists, the community clinics, the skilled nursing facilities, all of us are connected in coordinating care and really focusing on the patient home and really getting that data in a way where now we can parcel it out to the right patient home in a proactive manner. So I think HIE is the biggest challenge for us. We have not been able to do what San Diego has done and Denver has done and other coordinated care programs where the data is getting shared across systems in a proactive way and addressing the issue of PHI.
We'll look into it. Thank you so much, Dr. Bowman.
Jessica, I think you have a very important question, and that is, who pays for the pharmacist? We all admit it's a unique opportunity for getting better patient care and compliance, but who pays for it? Right now, it's been the healthcare system that has run around, looked at different sources to get a little money here or that. The reimbursement for pharmacists is spotty. So there are a couple of codes where you can get reimbursed, but it's not going to cover it. So that if you look at the entire state, to roll this out over the whole state, there are some healthcare systems will pony up the money and say we can justify it. But across the board, you're not going to get payment for the pharmacists right now. There have been a couple of bills introduced in the legislature looking at reimbursement in California from time to time. But right now, the reimbursement for pharmacists in the state of California is spotty. So it's not an ideal situation.
I did want to mention that the impact the pharmacist can make can really leverage the Medicare stars. We can bring, an organization from a 3-star level to a 4.5, and that's a large amount of money, through the medication adherence, through the diabetes, through the hypertension. And if you see it as a whole, we can show that we can make more than our salaries. The issue is it's not a direct solid line. It's more of a dotted line of understanding that quality comes from really healthy patients, and the money will come back through other sources. But definitely bring in the money. It's just not always as clear. We need to sell it that way.
All right, so we're kind of at the top of the hour, and I'm going to hand it to Hattie to close out the meeting. I will be here. I just also want to thank my team that's here in the room. I would ask them to stand and put their hand up so folks can see who they are.
Thank you very much. And before I give it to Hattie, there are just those forms or those sheets on your table. If you could enter in there, what if you think this is a preliminary card that's about to be printed. We made one more change to it. We added spironolactone as medicine on the back because that was recommended. And but there's a small change in it, that's all. If there are other important changes you think need to go on these hypertension cards in front, write them down. All of this information, this is vetting for CDPH. This information is going to be submitted, or Jessica is going to walk out with that data and use that as we move forward to printing. We want to make sure everything is correct and appropriate on there. The second thing on the question was who or what would be the groups you would recommend these cards get sent to, and how would we deliver them or disperse them to that group? You have suggestions for that at the same time. And the last is recommendations or volunteers, if you want to add that. This information will go to CDPH, and anyone who wanted to help or participate in this would be probably more than welcome at that time. With that, we want to thank all of the presenters today for doing an excellent job. Bruce had to leave early. We wanted to thank him for coming down. But the importance of this, I think, couldn't be stronger as we presented it today.
So I also wanted to just flag a couple of things. One is the reason we really want your feedback on these cards today is that our team, led by Dr. Balmer and the first version by Dr. Revelo, has been working really hard on making these just right. And thank you, Brian Vaughn, for being able to navigate all the changes that have been requested. But the California Department of Public Health is going to be printing literally thousands of these. So we want to make sure that before we hit go, that you all have reviewed it, that you want it, because we would like to provide them to your groups and distribute them to the groups around the state. Also, I want to flag for you that Dr. Balmer and cardiologists around the state helped to create this patient activation card, and Dr. Balmer specifically added the part on the back that is sort of the hook for patients to get them motivated to take their medications, which is to write down the name of the physician that a person's going to work with, and then it gets a little tougher. Who's the person who's going to take care of your personal hygiene and finances if you are disabled by a heart attack or stroke and unable to handle those yourself, and also your faith advisor, your spiritual advisor. So once you get somebody writing down, and he does this in his office, he has patients that don't want to take the blood pressure medication, write down the answers to these questions, and then they're usually willing to convert to take their medications. So Bill, that was a brilliant innovation, and we would like your feedback on these as well, and it's possible that the Department of Public Health will also help us print a lot of these for your organizations. We would love to gather resources to be able to do community outreach events. Yes, ladies.
I have a question about this card. Is this a card to prompt the doctor to ask these questions, or the care provider, or is this a card for the patient to read? Because the reading level is much too high for patients.
And usually readability should be at 6th grade level or below. So we make edits or comments on the card to help with
You
that?
could make a version for that setting, but for a physician to have a discussion with the patient,
Yeah.
or at a screening event.
Exactly. For the physician, I think it's a good reminder, but I just want
Great.
to know where we're going to go.
Well, it gives patients very specific action plans of things that they can do that would be best, started off as a conversation with a healthcare provider.
Those cards would be good for a non-physician in talking to the rugby team parents or the Rotary Club to hand out, because the speaker can answer. Those are not PhD, MD questions. Those are most lay people, especially those that know anything about their heart, will know. And those that don't, that's why you're handing it out to teach them.
So we are going to be using these in screening events at rugby teams, at faith-based settings. And yes, I've talked to many people and have used these to motivate them. People keep them up on their fridges, and I think a lot of people around the state have worked on this, so hopefully you'll find it useful. So just let me know how many you want, and we won't use these for your group. And
No, I'm just
another
saying,
thing
if-
could be
if
created
we're
for
just
them.
concerned if they're mailing them to patients.
We're not mailing them,
Delivery.
no, this is a discussion piece, yeah. So you can write your comments on these surveys, we really appreciate it. And I just want to say, and we're happy to stay and talk as long as you want, but I want to just flag for you that next month, Bill Balmer is bringing up, and the Right Care team is flying up Dr. Nathan Wong, one of the national cardiovascular experts from UC Irvine. And then we're working to put together a diabetes program for April. We'd love your help with that, Jim. I've asked Mercy if they would help with that, and Setter's help. I've also asked for, and then very exciting news is that on August 10th, if you can all plan to be with us, we will have the National Director of the Million Hearts Program presenting here. And we might make it into a half day that day. So with that, Are there any questions? I'm sorry that we kind of packed the program and we went a little over. Liz?
I just have one quick question. So all of you have talked about going to the doctor's office, you're rushing in there, you get your blood pressure checked, and then they check it again because generally it's a little bit high. But the second time they take it and it drops, what are they recording? Because I have found that they record the first one that's high, not the second one that's lower, and I've looked at that. So why are you recording a high blood pressure for me when I don't have high blood pressure? I just raise skinnier.
And we go into that.
Do you know what's funny is that all of us are having that experience everywhere with whatever system we're in. I went to urgent care because I actually had influenza A at a very fine urgent care center in this region. And the person who took my blood pressure literally held my arm up and didn't,
They usually put
it was
your arm on
it
their
was
hip.
it was the most absurd situation, and they didn't even say that it was a high blood pressure reading. And I said, well, I don't have, it was 135 over something. And I said, I didn't want to argue with them about their technique, but I think we're all saying that it isn't being done properly, even though we have tried so hard in this region to do it. So I would say, we'll be talking in a few minutes, Jessica, but certified training of all the health professionals in how do you measure it is one thing, and then another thing is, I am worried about what it means if when we're rushing, which we always are, our blood pressure's high. So isn't the more realistic question from a cardiovascular standpoint, when we're rushing around and we're not breathing deeply and relaxing, which how many of us ever are we damaging our hearts because our blood pressure is higher then?
So it's a great question. For the NIH trials we've done, there is training required of the people measuring the blood pressure. And we were going to go through that today, but we didn't have enough time. We ran over time. We had actually blood pressure cuffs there. We were going to go over the correct method for that, but we just ran out of time. So we'll probably try to do that. So there is in-service required for measuring the blood pressure at that point in time. Periodic blood pressure. You come into the office 2-3 times a year, get one single blood pressure. It's probably not the most accurate to reflect what you're doing. So in our clinic, and I didn't have time to go into it, what we're doing for our Prevention Forward program is putting on 24-hour ambulatory blood pressure cuffs. They record much more information, and they correlate much better with outcomes than the single or triple episodic times a year blood pressure. So there is better ways to do it. It's reasonably affordable right now with 24-hour ambulatory, and we're certainly going in that direction. The same for diabetes. A single A1C is not inaccurate. It measures your average glucose over the last month. While there could be highs and lows that were dangerous in that situation. So in our new clinic, as we're going forward, we're using basically monitoring, continuous glucose monitoring that is available on your phone or watch at that point in time. It does a much better job at preventing hypoglycemia, the dangers of hypoglycemia. So we have better ways to go forward. This is a first step to get that blood pressure, to get it measured and monitored. As we said, lower numbers we now have for targets, and there's reason to go for those. We have better ways to measure it at this point in time. So we're making tremendous advances along this line. We can't hope to achieve all of those overnight, so they will take time to accomplish. But we're making slow progress. It's progress, but it's slow. And we hope to go accelerate as we go on.
Okay, but let's celebrate our progress here. Each of these groups hit the 90th percentile nationally for top performers on 2 out of our 4 measures. That is amazing. That's huge progress, and thank you.
Thank you very much. Drive safely when you leave here. And if you want your blood pressure measured, Megan and Ryan over here will accommodate you at their table.